we may just go around the horn and just talk to people about different things because one of the things I wanted to do today was get the talk about tactical medicine today and in EMS. And I think I was going to have Dustin and Stein, but Stein got called in to some meeting, and he said he'll try to get off towards the end. And I think that would be kind of a fun thing to do then. So I'll hold off on that for now. The other thing is that Rob Dunn was going to give a talk about what he experienced in China and what he saw as part of their system at the time. And he just got called into a state meeting. So which leads us with maybe Roger, can you do us a little thing about, I'm going to go around and talk to a few people first, but then can you do a thing on what's the rationale and what's your protocol for using labetalol and stroke?
Sure. I apologize that my heads up of knowing I was proposed for today didn't leave me with PowerPoint slides, but I've got some visual aids in terms of PDF slides that actually show the protocols. Yes, I'm happy to try.
You know how we are. So I just want to go around the room real quick and see if anybody has any time problems that they have to get off early on. Let me know so I can get you in, make sure we've got you covered, etc. Okay. And so I'm just looking around for the usual things. Doug, haven't talked to you for a while, so maybe we should take advantage of you first and just give us a quick report and catch up. As president of what's that organization called? National Association of EMS Physicians, right? And I don't know if you have any reports to give us or anything you want to talk about, or discuss with us. I figured I didn't want to lose you, so I did want to get a report from you. So why don't we start with that?
Yep, that would be great because I'm largely out of pocket for this meeting. So can you hear me?
Yeah. Okay.
We
can hear you, sure.
Yeah. So I just returned. Several of us and some of the Eagles were there. Just returned from 2 days at the Government Relations Academy. And our day on the Hill, and we had an extremely productive 2 days up at Capitol Hill. Our bill is about to be. It may have even been put in yesterday evening or this morning, but our bill is about to be submitted. The representatives are Hudson on the Republican side and Debbie Dingell on the Democratic side. We met with both of them yesterday. They're going to put NEMSP's bill forward and met with a lot of other representatives and some senator offices and really seem to have really good bipartisan support thus far, and a lot of people that agreed to be co-sponsors once the bill is dropped. So. Yeah. That is good. Just a reminder to people, the three things are: number one, I
just want to say what's the bill and what it's about. Yep.
Okay. So I wish I could give you a number. I can't, but hopefully any day now we'll post numbers and get it out there. It has 3 parts to it. The first part is calling for a MedPAC study of sort of the value of EMS medical direction and how that should be valued. And then, that's sort of the first step to having some recognition of payment for that. We realize that, in many situations, the agencies pay their medical directors. We view this like hospitals paying their medical directors, but if medical directors are recognized and can be paid out of another pot through Medicare, that would be a big win for some that don't have budgets to adequately resource a medical director and enough time from a medical director. So a MedPAC study of the value of EMS oversight and medical direction is number one. On the heels of the MedPAC study that they just did on ambulance operations in general, we think this will be a nice connection to that. Number two is related to medications and blood. It calls for a CMMI project, and CMMI just this past week has been dramatically revamped. It's not going away, but it's revamped to have a different focus, and we think that this fits right into the focus. The call is for the 9 medications that we've identified as essential and should just not be unavailable to have an upcharge in a Medicare pilot. that we think will encourage more companies to keep them available. And then on top of that, the payment for blood. So this is going to be a CMMI project that is not going to be as restrictive as people saw with ET3. It's basically going to be sort of a nationwide pilot of funding for blood, and then CMMI evaluating the outcomes of that, the patient outcomes, the savings in the hospital later, and all that sort of thing. And then the third leg of the stool is wall time. And that one is relatively simple. It just calls on the HHS secretary, Congress, to ask, have the HHS secretary look at and further clarify that when a patient arrives under EMTALA at a hospital, they're the hospital's responsibility, and they're responsible, and they can't just sort of say, no, we're not ready to take your patient for the next 8 hours, and refuse to take a patient over until EMS or until they're ready. So we think EMTALA already covers that, but this has Congress calling on the Secretary of HHS to formalize the situation when the patient arrives. So, what is presenting to an emergency department? We believe presenting to an emergency department means EMS rolls through your door, your patient's presented to you, you are now responsible.
Yeah.
So those are the three legs.
That's great. Yeah, you're right, because EMTALA does cover. But one thing we just want to bring to that could be done, especially with this just extra emphasis going through the HHS secretary or whatever, is the issue that we're not supposed to be practicing it in a hospital. We're not credentialed to do that, and de facto we are. If we're monitoring the patient or running fluids in or whatever, even just saying that it's probably not so ethically we would never abandon them, but it really is their job to take care of it.
Right.
Yeah,
and we gave multiple stories to them of, EMS clinicians going back out to the truck to get medications to give to a patient that is deteriorating in the hallway because they haven't yet accepted them at the emergency department. The other thing that we think we made some inroads on was, our 2017 act that passed related to the controlled substances. That passed in 2017, but the regulations still have not been promulgated through the DEA. And we had some very good conversations at high level related to pushing that. Unfortunately, one of the things that was brought up was, well, will this be affected by for every new regulation that gets promulgated, 10 have to be removed, which is, the new process they're working under there. We were happy. We suggested we could probably give them 10. We would like to have removed in place of the DEA clarification for EMS. But I hope we don't get hung up with that. They didn't think that should be the case, and these the folks we met with at the on the congressional side that felt like they could put some pressure on DEA to push that through.
Yeah. Okay. Great.
So well, we're not holding our breath. We've been waiting since 2017, but I think we have progress on that too.
Yeah. Okay. Great. Well, good. Well, listen. Thanks for. And then you were at the SOMA meeting as well, right? Is there anything you have to report on that, or special operation, by the way, for others?
Right. Yeah. It was a good meeting. We had a leadership meeting there too. We identified some things that SOMA and NAMSP can connect even more on. So all in all, that was a good meeting, and the SOMA group is a great group. It's always fun to hang out with them.
Yeah, good. Hey, anybody else either at that is on the line today to make commentary about the visit to the Hill or SOMA? Anybody else here that's on that wants to make commentary or add to the discussion? Give us your perspective. And you identify anybody here? Yes. Yeah, go ahead.
It's Art. I'll only add to Doug's remark. I think one of the themes that is a clear concern, and SOMA impressed me because there were a lot of international folks there. Europe, primarily, but also Asian members, Ukraine, and others. But I think special ops folks are very concerned about the very rapidly changing nature of the battlefield. And with drones, large-scale combat operations, potential for, every trauma response being a mass casualty incident, not just a 2s or 3s or 4s or 5s. And then most importantly, the prospect of having to deliver prolonged field care.
Yeah.
As in not just hours, but possibly days before you can get somebody out of a bunker or even off a battlefield. And that will be a very different logistical challenge than those good old days when we had air supremacy and you could have a medevac and with all likelihood get somebody off the battlefield within an hour and back to the U.S. within 2 or 3 days. That's not going to be possible on a future battlefield. Over.
Well, and the other thing is that you bring it up because in several festivals that I've been involved with recently, people were sending drones in, instead of helicopters like the news stations or various things were covering it. And then there were people that were supposed to be there, but sometimes we didn't know, well, is that the one that's supposed to be there?
Yeah.
And that they can come and deliver, a badness, is there. So there is that issue as well, in our own environment, I guess, right? So
yeah.
Okay. Anybody else that was on the Hill or at Soma have any commentary? Thank you, Art. That's great perspective. And we could all sleep well tonight. So, anything else? Sorry. I just got another commentary for one of our speakers says that they're in a meeting with their fire chief and can't get out right now. So this is good. All right, so that's okay. We could do something we haven't usually done, which is we can go around and talk to everyone. Are you here for the duration, Mick? Are you here for the duration out of Ireland?
Yep.
Mick? Yep, they
Yes.
good. So I'll come to you later on, that kind of thing. So literally looking forward to having you at our meeting, and we're going to have some great discussions, and you'll be really integral to some of the things we're going to do about mass gatherings. All right, Sue. Hey, Lexi. First of all, Kevin Joels, are you there? And do you have anything to add to what you heard from Doug so far? You there, Kevin?
Yeah, sorry about that. I'm just stepping out of a meeting.
Yeah. Oh, okay.
Yeah, I apologize. Hi, everybody. I don't have much different than what Doug has talked about. We've been, I don't talk to Doug personally all the time, but I get a lot of the emails and support. Some of the stuff we can't move on as fast just because it comes at us pretty quick. And so we answer to a board as well, just like most everybody. So we do support, pretty much everything. It's about 95% of the stuff that we're doing. We support each other. And that 5% typically gets, left behind, which is fine. So I don't think I have anything to add today, but thanks for the opportunity.
And then you move up through a different food chain with the fire service then, so they'll be independent of this?
With the International Association of Fire Chiefs, the EMS section, anything that we need to get approved or in support of, whether it's another organization or internally, has to be approved by the executive board, which typically with good explanation, usually as well, if it's there's a lot of agreement with other entities, it doesn't typically take too awful long on some things, but occasionally there's some slowdown, as you know.
Okay, well then let's talk to your medical director for IAFC, Jim Augustine. What do you have to say?
Hey, thanks, Kevin. Thanks. You just had the Fire Rescue Med meeting, and I hope it was a very successful one. I look forward to attending next year. The IAFC just released information about enhanced domestic manufacturing of medications. How about this, Paul? So ASPR working with Health and Human Services, DARPA, and Mark Cuban Cost Plus Drug Company are looking at producing the emergency medicines that are needed in the country. So I'm going to distribute information to everybody in the group this afternoon about this. Cool. So I'm going to add on to Kevin's report and say this information came across, and it would be exciting if we can get to reliable supplies of our medicines. Right now, the two key shortage medicines are amiodarone and hydroxycobalamin. Thanks, Paul.
Okay, got it. Okay, thanks a lot. Let's see, any other organizational stuff then, from anybody, I guess, since we're on other societies thing. Anybody here from ACEP on that needs to say anything? I can't see anyone right now. Well, the only person ACEP, I guess, would be you, right? Lexi, how are you? You have any of your fellows on with you today? What are you doing today? Lexi Azra, are you there?
Come back to me to Paul. I'm on the phone.
Oh, okay, got it. I'll just, yeah, I'll do that later. I was trying to see if you had any visiting fellows from other countries with you and all that today. All right, so let's see what's next. John Kramer, yes.
Well, I apologize for joining late. Did you, or has anybody brought up yet the HHS budget proposal to move ASPR and zero out the hospital preparedness program?
Not that I heard, right? Anybody else hear that? I didn't. So go ahead and tell us that, all right?
So, well, I know very little of the specifics. I'm trying to get them, but for folks' awareness, the HHS proposed administration budget zeroes out the hospital preparedness program and moves ASPR organizationally, administratively, and operationally under the CDC. So as a covering Fed, both of those things are worrisome from my perspective.
Yeah, because I mean, it's great and for some aspects of all that, but for the majority
No,
of,
it's not. No, this is not a great issue. No,
okay,
there's no positive associated with this.
okay, got it. I understand that. Well, and it should be probably for some receipts, yeah, I get it. I understand what you're saying then. But so I'm saying, but for the 90% of everything we deal with, it's outside the CDC's realm is within so I agree with you, John.
Well, but if ASPR moves to the CDC, it will be decimated.
Yeah, because also they're probably going to decimate the CDC itself. Probably that's a good way of doing it. So
Maybe,
right.
yeah.
They've already ripped the CDC to shreds, and anybody that has any insight into what John's talking about isn't there anymore.
Yeah, right. So, okay, yeah, well, okay, so I'll rescind my statement and say that's awful. Yeah, but that's the thing. It was already CDC was going. That's why it's a bad in all respects, anyway. So, let me see. Let's see. Oh, we got Dustin over here trying to get him. Okay, over there. Dustin, go ahead. Did you have your hand up? Did you want to talk to us about something or other?
No, sir. Hand was since they get in. I was late. Fire chief just wouldn't stop talking.
Oh my God, the fire chief wouldn't stop talking. What's the story there? Okay, got it. Alrighty. So we haven't had Stein on yet, so we're going to put your. It's fine because we're going to put your talk a little bit on hold for a bit till he could get on. Okay, he said he'll come on, but it's going to be he'll be late under that thing. So I was just kind of going around the horn right now with different commentaries that we had. But let's go ahead and do a little kind of a didactic or kind of informational thing. Libby, go ahead. Can you just tell us the commentary you just made?
Yeah, so in Hawaii, our guys are already telling us that they're being shifted under CDC, our ASPR folks. The other scary thing is that, we get that hospital preparedness grant, and it essentially funds emergency preparedness. It's kind of the state sort of passes it through to Hawaii Healthcare Emergency Management, and so we almost entirely fund them. So without that grant, it's like $800,000. That entire entity is just going to disappear, and that's the coalition for all the hospitals that does emergency preparedness.
Yeah, yep. Interesting. Okay. So, and then, hey, going back to John Kramer, since you're close to Rick Hunt, does that mean we lose Rick in this vital positions that he's been playing there?
Well, Rick and I have been exchanging information. He's in the hospital preparedness program, so if it's eliminated, he's gone.
Ah, God, that would be a real tragedy. Yeah, because he's so great. Yeah, what a great person. To have in that arena. All right. Well, this is definitely, thank you for everybody's bringing us great news today. Sleep easier news from drones to collapsing some of the best things we had going. So I'm sorry to hear that. Well, keep us appraised with it, John, and let me know what goes on. There's nothing we really can do about it, right? Andy, can you say anything about this, since you were in that realm as well before with Asper for the longest time?
Hey, I still am, and I wish I had extra information to give you guys, but that's the word on the street is, yep, we're going to CDC. No one's said anything about how they're going to do it, and to my visibility, they have not hired a new assistant secretary. So the principal deputy assistant secretary has been in the Mr. Don Knox has been in the leadership role for Asper for months and months now. They're being pretty tight-lipped of how this is going to impact hospital preparedness program. Obviously, I'm pretty concerned about the impact on NDMS. I don't know anything. I wish I did.
Well, okay. First of all, as absurd as it is, what's the rationale for this? What are they thinking? I mean,
there is no rationale.
Huh. So, I mean,
There's no rationale.
Got it. Okay. We're just trying to make government more efficient, right? By getting rid of it.
Paul, it's hard not to editorialize, but I think the idea is to be as disruptive as possible and then build something new and really amazing. That if you listen to the political rhetoric. So a lot of this really is not, there isn't a grand plan building the watch. It's break the old watch and then we'll create a new watch.
As if
in our vision, whatever our vision happens to be.
Right.
Nutrition.
And Paul, and Art, you're more of an artist on this than I am, but we need to talk with our nationally elected representatives. They need to understand how really stupid this is.
Yes.
John, if you're willing, and Paul, tell me, shut up if this isn't doable. Even if you did a one-pager that is to this group, not as an official communication, but just background.
Yes.
Then we can put it in our own words and make our own spin when we reach out to our respective elected officials. Over.
I think it's good because we try to take a point of view that this is not a organization.
Not a partisan issue. Yeah, exactly.
Yeah, but if people like Doug or the others here or Jim Augustine, want to go through their organizations, then they can do the position paper. But I think what you're saying is absolutely on target. You're saying we're going to give you a one-pager informational why this is a bad thing or whatever, and what's going to happen with it. Yeah, it would be very useful. Let's and then why don't we jump over to Doug actually for a reaction, and then I'll go back to Jim Augustine. Because you guys have already been decimated. The fire administration has been the fire academy, just National Fire Academy. They've already trashed that as well. So Doug, so what do you know about it here, and what do you think about? Can you guys do a position paper, and is there anything of?
Sure. Yeah. A number of us in the leadership were talking yesterday about what we can do, and it's such a sensitive thing. I think we want to have an impact. We want to let people know about the important things that are being stripped away. But, at every half day, there's something else, and then it causes things to look reactionary. But, I just put into the chat that a couple other things that we talked about yesterday were that NEMSAC is pretty much on, and I don't know if Brandon Marchetti is on, but NEMSAC's pretty much on like an indefinite hold, and all the projects and things they were working on and the advice that they give from the EMS standpoint to the federal government is essentially all on indefinite hold.
So Doug, so Doug, just for some of the folks that are on, can you explain to them just real quickly what NEMSAC?
Sure. Well, NEMSAC is the National EMS Advisory Council, I think. I don't want to. I want to make sure I get it right with the C, right. Council. Yeah. It's a group of folks that very specifically represent all types of EMS. There has to be rural and urban and fire and private and air and just all aspects of EMS. And then they're an advisory group to FICOMS, which was the federal interagency committee on EMS. And then they're essentially non-functional right now. FICOMS is, and NEMSAC is just on a permanent hold. And they had a number of projects and advisory positions and things that they were working on and about to, connect with FICOMS on, and those are just all on hold.
So, Art, if you want, why don't you go ahead and start putting some together, and then, can collaborate with John Kramer and Doug, and or anybody else wants to join in, but those I think would be the most knowledgeable people who could do it. Joe Holly, you're state EMS medical director, but you're also been well plugged in with, particularly NDMS teams, et cetera, and working under FEMA over the years and done just an amazing heroic job for us all, you and your wife. And what do you think's happening? You're thinking that FEMA is getting dismantled too as well. What do you know about that?
Yeah, I don't know much. Just excuse me, a lot of rhetoric around the recovery side, which is the insurance side and reimbursing people for damage to their homes and all that sort of stuff. With some meddling, for lack of a better term, on the response side, the USAR side, in that we've seen a significant reduction in continuing education efforts, and many meetings have been moved to virtual and that sort of stuff. So,
well, I've heard that, the rationale there, again, remember when I say rationale, it doesn't mean it's rational, right? Is that they want to push it all onto the states, which of course we know, especially when it's multi-states, et cetera, and there's got to be federal coordination. So, we all know that, but I'm saying that's another one of these things that we might want to add into the mix here on all that. And then, hey, Andy, Garrett, if you want to help, because you're kind of in the mix, that's a conflict of interest for you or whatever, but if you could also give them some insights to whatever you're learning too as well, it'd be helpful to the group. So, all right, so can I make Art, does anybody have a problem with me just saying arbitrarily, Art, you be a point person and then work with Doug and John on this as well? We got points of information for all of us. You're muted, by the way. Okay.
I know that drafting is how it works around here, Paul, but if the folks that are close to the issue can even just bullet points, or here's a few things, I can certainly craft the type of communication that a congressional office finds helpful. Not rhetorical, not political, just factual.
Right, good. Yeah,
but I need the facts.
You're such a master at that, so that's great. Okay, good. All right, unless anybody has objections or can tell me personally, that'd be great. Dr. Glatter, are you here today?
Yeah, I was going to say, I'm happy to amplify the message of this white paper once it's produced through Medscape, and to really, once obviously other channels would be amenable, I'm sure, but certainly if
okay, well, we could do that, and then that just gets facts out, because I don't think it's be a white paper, it's just a fact sheet. I think that they're talking about doing, trying to make this political. It's just an informational thing to folks if they care about this. They should be aware these are going away. Here's the problem, that kind of thing. And so here's the quasi solution, because it ain't gonna be a solution, but for what it's worth. Okay, thank you then. Let's see now. All right. Well, I think at this point in time, then that's enough of that depressing conversation, I think, unless anybody else has anything else to add in there. So thank you for bringing to our attention and stimulating that conversation with you all. By the way, speaking of which, I think Cherie, are you on today?
I am.
Yeah. So what's the word? Is it going to be affecting NEMSQA? Your projects?
Not directly right now, but I would say there's obviously just the concern of future projects and what funding opportunities get removed or taken away because of all of this, but nothing directly impacting right now.
Okay, got it. All right, so let's quickly go back to just move along, go into other fields here. And then let's quickly go over to Lexi. So who do you have on for you? Do you have any fellows with you from other countries?
I do.
Okay.
Sorry,
Who-
I've been on the phone all day. This is day 2 of no radiology.
Oh, wow. Okay, that's interesting. So you have to like read your own images?
We have to send the patients to another hospital to go get scans done.
Oh, I see. Oh, God, that's
We're
even
efficient.
worse. Okay.
Yeah, great. Anyway, yes, I have some.
Are you're near that foreign country, India?
Hi, hello everybody.
Yes.
Okay. Now, who are you? That tell us, introduce them.
We are in Italian residents, emergency medicine, just here for the month of May, and following Dr. Ezra today.
So they get to see the meltdown when we have no radiology.
Yeah. So
yeah.
Is Italy the one that sort of comes down like below like Switzerland? Is that the one? Is that right?
Yes, that's the one. Yeah.
Okay. No, but whereabouts in Italy are you from? What program are you with?
We live in Milano.
In Milano. Okay, good.
Yes, no.
All right. Well, thank you so much, then, for being here. So
Thanks for having us.
Yes. All right, I gotta go. I
Okay.
gotta run. There's stuff to do, but I'm gonna leave the meeting for now. I'll come back if I can.
Very good.
I'll see you
And
later, Paul.
See you later. And I know these are a lot of us is our local politics and problems, but I bet you're not unfamiliar with that with your current leadership, so to speak, in the country. So anyways, it's interesting. So we're going to go on to more medical topics now, and hope you'll enjoy that. All right. So with that, and before I do that, there was someone I wanted to pick on here. So, hey, Erica, how are you? Good to see you. How much time do you have, Erica?
Hey, good morning, Paul. My next meeting is the FIFA one at 11:30, whatever time that is. So,
all right. Well, I'll just get you. I'd like to get a report from you real quick. It's good. Well, is there anything new in Kansas City besides?
Oh, a new city manager, maybe a new fire chief, maybe a re-signed contract, and a whole heck of a lot of people coming our way in 2026 for the little thing called the World Cup. So
Yeah. Well, anyways,
just lots going on. Yeah.
You're a busy person. So, okay, we'll try to get back to you, but I wanted to say hi to have you.
Hi.
And then,
yeah, it's good to see you.
Yeah, good. Hope this is of use to you. And then Josh, great to see you on, et cetera, and so on. So let's do this. I will go ahead and just sort of give our kind of quick didactic that Roger was going to do. And it's going to be really quick anyways, right, Roger? So, but we just want to tell you what's the rationale and what you're up to there, okay?
Sure. Am I able to share my screen?
Well, Julian, is he able to? I want you to try it and see if you're able to.
All right.
And
let's see.
Should say Mark.
Yes.
Participants. Okay.
Are you seeing this?
You're coming up. There you are.
Okay, gotcha. So the timing of talking about our hypertensive emergencies protocol in Maryland is pretty fortuitous, because just on Wednesday, you can see here the agenda of our protocol review committee. And essentially, under old business, this is a topic that had to go to third reading. It's a little bit almost like going through the legislature. And the reason is that it was originally proposed back last year by a rural county, Allegheny County, Maryland. And what they noticed is that they were having a lot of patients who were fairly severely hypertensive with long transport times, and they felt that a certain amount of them could benefit from a blood pressure reduction. And so they originally proposed an all non-standing order protocol for labetalol at the time. And this was actually while we were also discussing hypertensive disorders of pregnancy. And that's going to be relevant in the discussion here, because once we got that through, which was a Montgomery County proffer, and by the way, thank you to the Eagles, because you guys were all discussing that, Ben Weston and others. When we got that protocol through, we actually then began to have labetalol beginning July 1st on the rigs. So we were left with the medicine in the formulary, and it was important to talk about what other indications could be helpful for patients. But we had pushed back against Allegheny because we generally don't like all the addition of medications where you have to ask each and every time. We were more looking for indications for standing order. And with the so we sort of took over from Allegheny County with proffering this. And what we did is, one of these full packets that you need to present when you go to the protocol committee with a new innovation or a new idea or a new protocol. And so we did a literature search, and although there's not, well, first of all, there's a big concern that in the urgent setting that we may be treating hypertension in certain populations without that much benefit, and certainly there could be harm to a certain subset of patients if you're reducing blood pressure without any rhyme or reason. So what we had found is that clearly in the stroke cohort, there's a benefit of blood pressure reduction in hypertensive patients experiencing hemorrhagic stroke, and a little bit less direct evidence that if you treat hypertension with patients with ischemic stroke, that you're not at risk for potentially adversely affecting collateral circulation. In other words, overshooting and increasing the penumbra. So what we did, however, know is that obviously if you want to treat primary stroke centers want to provide thrombolytics, or even if you want to do thrombectomy type interventions, that all of those patients who come in severely hypertensive need to have their blood pressure reduced to approximately, many of the hospitals have 185 systolic blood pressure and maybe 115. They have to be under those thresholds to be able to treat them in the first place. So our literature search showed that, first of all, there's a big burden of hypertension and morbidity and mortality from ongoing hypertension. And obviously, there may be a group of patients who really need to be reduced in the acute setting. So if you look at this, I think, I'm not sure if you can see my cursor here, but clearly, although the literature is not all that strong on randomized trials, and those trials that do show that there may be a harm of overtreating blood pressure, many of those studies that were showing harm were starting out and treating blood pressures that were a lot lower. So their threshold was a lot lower. So what we proposed to do is we looked at this in the literature. You can see that there's almost like a Goldilocks relationship, where if you have patients who are either dropping their blood pressure to a point where they're not enough to support cerebral blood flow, or your blood pressures are much higher, you have much worse mortality. Here's dead within 14 days, and you see there's this U shape, and in the bottom of the U is that ideal blood pressure.
Let me interrupt you, okay? Because there's a little bit of I want to make sure, when we're looking at this. So on the over here, what's on the x-axis that says what? What is that? Dead within?
So it's baseline systolic blood pressure in millimeters of mercury.
Oh, okay. Right. And then on the y-axis is their death rate. Okay.
Is mortality, which is death within 14 days.
All right.
And so when we were doing our literature search, what this essentially shows is there is this in the middle blood pressure that is more ideal to try and obtain. And you don't want to overshoot by dropping people's blood pressure too precipitously. But at the same time, more severe hypertensive patients do not do well in either hemorrhagic stroke or even ischemic stroke. Okay. So what we proposed is are you guys seeing the flow sheet here?
Yes.
So what we did is, between the second and third reading, we actually developed a work group with our neurointensivists and our stroke neurologists to actually go through their viewpoint about the literature. And they looked at this and they found that this would be a sound approach. And so what we did is we divided our patients into 3 different kinds of potential hypertensive emergencies. The first is the acute neurologic presentation that is deficit driven and would otherwise meet the criteria for what we call a stroke alert, what commonly across the country is a stroke alert. And if the patient has a combination of these types of deficits in the setting of what we call severely elevated blood pressure, and we, after looking at the literature, we settled on systolic blood pressure of over 220 and a diastolic blood pressure of over 120, that those patients were probably going to benefit and were not at risk for a lot of adverse outcomes for standing order labetalol by the medic. And so what we proposed was the stroke neurologist said they probably would have been okay with the same 20 milligrams that we're giving the preeclamptic patients, but the state medical director and others felt like we could always add medicines, you can't subtract them. And Maryland's always been a very, very conservative state. So what they proposed was a standing order for 2 labetalol doses of 10 milligrams over 2 minutes, and after rechecking the blood pressure, they can give another one after 10 minutes. And so this is followed by a consult requirement if we want to give more. And if we get on the horn with the doctor, it would be like, well, what is our blood pressure? What would be our blood pressure target? And we also know that although we're trying to avoid, treating asymptomatic hypertension in the acute setting, we believe that there are a cohort of patients who do have who are at risk for like basically the patients that are likely to or possibly going to be subarachnoid hemorrhages and who have other neurologic symptoms such as severe dizziness, acute onset headache, or altered mental status or visual disturbance. And if those, what we want to do is sort of jog the medic's mind because they don't have a CAT scanner, but we wanted to not take it out of the shadows and say that if you think you might be dealing with the worst headache of your life, a thunderclap headache, we want to allow the medic to consider the possibility of the benefit of having the labetalol. And therefore, this is a consult, an indication for them to feel free to consult the doctor for a blood pressure target goal.
Okay.
And then if they obtain permission, they would give the same labetalol times 2 with a max dose of 80 milligrams after the plan is made.
All right. So I think we got the general idea here at this point in time. So I just want to now go out to the group. Is there anybody else using this type of protocol? Have had experience with it? How did that go? Or what's your reaction to this, or any critique of it, or any concerns? Anybody want to pipe in here on this? Let me see. Okay, then Roger, why don't you go ahead and take it down if you don't mind.
Right,
Okay.
right. So
Yeah.
just and then just to briefly mention the third type of patient that we wanted to include in this, and that is patients who at least suggest to be at risk for acute aortic syndrome. Sometimes, a radiologist may even call 911 from a radiological suite where they make the diagnosis and the person's having chest discomfort. So we may actually have the luxury of knowing. But in a case where someone has tearing, ripping back pain and other differential blood pressures and other evidence of aortic syndrome, we also are allowing them to achieve blood pressure reduction with a consultation using labetalol. And here, those patients actually will definitely benefit because every single heartbeat with a shearing motion is detrimental to those patients. So this is what we had done, and I was curious to see if now there are 10 states that have a protocol, and I didn't know whether some of the Eagles have this in their protocol and have had success with it. So with that, I'm going to try to end my share.
Okay, good. Now I may be wrong, but I suspect David Miramontes will have something to say, right, David? There you go.
Yeah. So, Roger, I think that's a conservative first step. Ours is really more focused on the systolic blood pressure of 220. And it's funny, every time I get a new batch of medics graduated, our call group gets blown up because we require a 100% physician consult for labetalol, except in pregnancy. Okay. And 9 times out of 10, we're like, no, don't give labetalol. Give them some fentanyl for their back pain that's making their blood pressure up. Or no, give them nitro and CPAP for their CHF, and that's why their blood pressure's up. So the differential diagnosis is key. And that's why we in our group have made it a physician consult. And my conservative nature has borne out that was accurate. Now for pregnancy, we don't care. 140 give MAG, 160 give drug, MAG and drug. But for hypertension, I mean, a healthy blood pressure in San Antonio is above 180. I mean, that's norm,
Yeah.
right?
Right.
So anyway, and Laura, that's our stroke group bought into this as well. And Roger, I think you're doing a good job.
Great. Okay. And then, hey, let me jump over to, if you don't mind, Vicente, if I bother you, since you both worked in Europe. I want to know if there's a different thought process there or what they do there. You're probably familiar with that, whether you were when you were in Madrid with Summa or your current thing in Iceland. And then with your background where you're used to giving people medications. Any thoughts or reactions to this?
I was checking the stroke protocol, and the window to modify the blood pressure is 120 to 185 millimeter systolic. We do have labetalol. Paramedics do not need contact with medical direction to provide labetalol.
Okay, because they're not too far off then. Okay, good. In concurrence. Okay, then let's see. And then Doug, tell us about, again, we put this out before, but if you don't mind, go ahead and do a renotation about the guidelines on elevated blood pressure emergencies in pregnancies.
Sure. Many may recall that that's a part of it is the elevated blood pressure in pregnant patients over 20 weeks, but there's also postpartum hemorrhage and several other things in those guidelines. Those were developed by ACOG with input from NAMSP and others, and they're co-endorsed by multiple organizations. So our sort of quarterly webinar that NAMSP does with Prodigy airs on next Monday, EMS week, and it is on the topic of that. We have people from ACOG on the webinar and NAMSP and others, and it's covering that. So if people want a deeper dive into it and to better understand those pregnancy guidelines, feel free to join in. You can get AMA Category 1 credit for docs and credit also if you spread it around to your, it's unlimited. Anybody can join. They don't have to be members of NAMSP, so you can send it out to paramedics and EMTs in your system, and they can get CAPC credit for it.
All right, thank you. So I don't know, unless anybody else, please raise your hand right away on this comment. We're going to move on from there. I just wanted to sort of put that out and how their thought process was and how they went through it to get there. So thanks for the good work. One thing that did come up as a red flag during this conversation, Dustin, can you articulate this a little bit more? Dustin Calhoun.
Yeah, being from Cincinnati and constantly standing in his shadow and seeing the things that are done in San Antonio and hearing my people say, oh, why can't we do this? I'm pulling the bullshit flag on Miramontes as having any sort of a conservative nature. Just saying.
He says anybody would, either, well, maybe David's just getting in his old age and he's getting conservative, right? That's what it is.
Hey, who's calling who old, buddy?
Here we go. We're back to Eagle style. This is good. I love it. Thanks, Dustin, for pulling up the flag. I really appreciate that.
One more thing real quick. In the packet, we do outline that the exclusions from the target population include those patients who otherwise the assessment drives you towards CHF and other target organs that have their own protocol. So there's a place for nitro. We have IV nitroglycerin and pumps, and that program's working well. So we steer people away from that. This is just the folks who would otherwise be a drop dead stroke alert. And that's why I think our neurointerventionalist said that this standing order was okay.
All right. Well, listen, let's see. Let's go ahead and then start moving along. Yeah, let's go ahead and start moving along, and maybe just as we're still waiting for Stein to come on, we'll just go around some of the cities and all that, particularly for people we hadn't heard from for a couple of weeks. Erica, you gave us pretty much a quick summary, nothing real special except that your whole city's up in the air with the new manager, new fire chief, and who knows what you're going to get into. So, but we're with you. Please, thanks for being here.
I think you'll like that. It'll be my 5th fire chief. I think you guys like those numbers. So there you go.
when you get sick, then you go into the 6 timers club.
Oh man, I'm hoping to stay at 5 for a little bit.
Saturday Night Live has the 5 timers club, but we have the 6 timers club. So it's good.
Well, I got 5.
But it also, that's an extraordinary short period of time too, in which that you've been there.
Yeah.
I think for anybody who doesn't know, Erica is now the state medical director there. They wanted to doubly punish her for doing such a great job.
All for free too,
Yeah.
tourism there.
So, hey, and then Erica is going to be part of our panel that we're going to be talking about and coming up with some common themes or just lessons learned when we
Yeah.
meeting there on June. So she'll specifically address something that's still an issue, for some of the, it ain't over till it's over because of the psychological components with their residents and so on, who were there at the shooting, at the Super Bowl parade. All right.
Yeah.
And we got a lot of our great people. And of course, we'll hear, Meg is going to talk about the truck crash, and we will have, also, Dave Over we'll talk a little bit more about, for the audience, what happened in Vancouver, and we'll have those common themes. And Nick, remember you helped to set up this thing last year at NMP, that sort of spontaneous meeting, Erica, remember that last year? And Nick Kazi, are you on? Nick, are you on from Chicago? Let's see if Nick is here or not. I hope he was here. He worked overnight, so he may not be on. He may have got bailed out. But anyways, Nick, I was having lunch with Nick yesterday, and he said it was the best meeting. So I want to give you the feedback, that you did a really good thing there, and the meeting, because it was spontaneous. It was really informative, and so thank you for setting that up last year. So we hope to continue it, is my whole point here. Okay,
I appreciate you. Thanks, Paul.
Okay, good. All right, so now let's see, Jared, anything out of Nashville while I got you there?
Yeah, I was interested in multiple of these topics. I've had a lot of Levada questions. We're also getting ready to kick off CMA in a few weeks, so the drone at festivals commentary was interesting to me. So other than that, we're getting ready to roll out some Lucases, so doing some training on that. But otherwise, all is well.
So that time when I came out, you weren't there, but your running buddy was there with me at the stadium when we were, what were we with, Garth Brooks or something like that? We had the big thunderstorm, rainstorms, and alert systems. Well, Justin McEwen, who works with us a lot on a lot of these things, and everybody's met, he's come to our Eagles meetings, was talking to me about a new, what's the word? It's a public announcement system that looks really very cool and very progressive, that we all can use in these various situations. They're actually using them in hospitals now and school systems in the UK. So I'm really learning. It just reminds me of when we were making the announcement about getting people cleared and where to go during that rainstorm. That was just something, that was an adventure, especially when you're out a golf cart going up 7, whatever ups and downs with the crowds there. It was a really interesting time with you guys. But anyways, this may be a really cool alerting system and telling people what to do in real time. So I think you will really like that when this comes up. All right, so thanks, Jared. And let's see now. Let's see who else was Josh Gaither there from Tucson. Josh, we hadn't heard from you for a couple of weeks, so wanted to catch up with you as well.
Good morning. I actually don't have a lot. It's a beautiful time in Tucson.
Okay.
So we're excited. We have a lot of students graduating. Today and tomorrow is our commencement ceremony. We have a couple dozen Bachelors of Science and EMS students graduating in 15 minutes. So that's super fun.
Josh, could you mention your new fire chief?
Yes, we do have a new fire chief. I think we talked about that a little bit. We have a new fire chief down here. Been in place for a month now. So
where is he from and what's the background?
Chief Sharon McDonough is an internal chief.
Oh, good. Okay, great. Sounds fantastic. All right. Well, good. Well, good luck with that. Let us know how that goes, right? And it's great to see you, Josh.
Yeah, likewise.
All right. So then let's, hey, Mike Feldman, are you coming down to the Eagles meeting? I can't remember. I think they asked me if you were coming or not. I can't remember.
I am coming. Yeah, I'm looking forward to it.
Do you have your hotel rooms all set up and all that? That was the main.
Yeah, I wasn't able to stay at the primary hotel, so I'm going to stay down the road.
Well, we'll let you, if someone has to cancel for the last minute, because that happens, like we had just here locally, someone I was going to get together with, a major emergency came up with family member and couldn't, so we'll try to see if we can get you over there. But either way, it's a nice place to stay. In some respects, it's a lot nicer place to stay, but it's just the inconvenience of traveling back and forth, that's all. But I'm glad you're going to be there, so that'll be very, very cool. So good. All righty.
I'm looking forward to it.
And let's see now. Trying to catch people I haven't talked to for a couple of weeks. And so Ben Weston, well, we've talked to you, but what the hell? I just see your name, and your name came up so much yesterday with Nick Kazi and I cruising around talking about, us preparing the next set of people for the conventions that are coming up. like David Purse is going to have the RNC, and it'll be good. And we don't have, they haven't talked about the Democratic convention yet, right? We don't know where that's going to be. Is that correct?
Right. I have not seen it at least yet.
Yeah. Okay. Because
Yeah, no, we had great experiences with the RNC, so certainly happy to share that.
Yeah. So I'm saying, is that then that's where David's got the RNC then, I think. I don't know. They're going to Houston, I think. So that would be great to get David Purse. I had a great time with David Purse and Chris Souders last week. So good. All righty. Well, I got you on, Monsieur Public Health Authority, and and all around great guy. Anything new, Ben, out of your shop?
Nothing new probably of too much interest to this group. We did just tour. We're having a new building that we're all moving into for our EMS administration. So it's opening in a few months, and we got to tour that. So that's locally exciting, but otherwise things are going well.
All right, good. Great to see you. Looking forward to seeing you. Okay, got it. Well, next on the list, I'll just go down the list here. Jim Augustine, anything either for IAFC or yourself at Lee County and your cities of Cape Coral and Fort Myers?
Yeah, we are modifying and updating our blood program, which with the help of a lot of the Eagles, we can be more specific in applying our blood program. And then with all of your help, we're doing the OB programs. So building out our hypertension with the same model that has been used across the state of Florida, and then from ACOG that just published it. Drug shortages, again, are the critical issue. And I just sent out to all the Eagles, Paul, that announcement that I gave to you. Thank you.
Okay, got it. One of the Nick was gonna we'll contact you later, but Nick and I were going to he wanted to ask a question of the Eagles, and I said just a simple thing to say find out who has such training programs. I'll tell you what it is in a second, and then just get in touch with them individually, because they're actually setting up a technical rescue training thing for EMS, and as a specific area of subspecialty, so to speak, amongst their group. You want to know who had programs, how does it work, and all that. So I'll be putting him in touch with you to set up a very simple survey that we could send out. So, all right.
Very good. Thank you.
All right. So let me see now. Art, anything?
Paul? Hey, Paul,
Yes.
can I ask one issue? Can I put out a request for everybody to update their data so that we have it for you when we do the Eagles meeting in a few weeks?
Okay. So what he means by the data, like what are the 4 or 5 questions that we want to know, Jim? There's one is what's the population of your city, right? Or your catchment area?
Population, number of organizations that you provide medical direction, you or your office of the medical director provide for. What are the number of providers that work under your license or the group's license? What are the number of incidents? And that's it. So it's a 4-question. We can send it out as a survey.
Yeah, once you do that, maybe work with Mark, so you don't have to do all the work compiling all that stuff or whatever. That'd be good. But yeah, so let's make sure we understand when we say, because for Eagles, we generally talk about that we're people working primarily out of municipalities, but some of us have whole counties and so on. So like the case yesterday with, in Aaron Burnett's case, he's got St. Paul, but he also has some other regions. So we're lumping it together because we're saying the group is responsible for, not 1 million, but 1.5 billion in that city kind of thing, right? Is that how we're doing it?
That's correct. Yes, sir.
Okay, good. Okie doke. Just going down the list here. Hey, Art Kellerman, anything you want to add into it? Thanks for being part of the discussion here today, by the way, right? So.
Oh, you're welcome, Paul. I just, not for immediate action, but I'm working with a group of folks that have been putting a lot of time and effort into getting approval of ketamine as a pre-hospital analgesic or an emergency care analgesic over the hump with the FDA.
Okay.
Number of EMS agencies do it as a off-label use. The military has been using it for 14 years very effectively. There's a new phase 3 randomized controlled trial that shows it's comparable again to morphine and very safe and obviously non-addictive. But the FDA is always, we need a couple more studies, or we need one more study. So Special Operations is very interested in this issue for obvious reasons.
Yeah.
Military has got burned about 8 years ago with a contractor that took a lot of their money and didn't get anywhere with the FDA.
Yeah.
There's an outfit now that has a very durable emergency injector for fixed dose standard administration, which aligns with all the major emergency care and Scottish Society's recommendations. So we're in half the distance of the goal line. Every 3 or 4 months, we get a little closer, but we're not in the end zone yet.
So one comment, obviously about the study we just put out about ketamine for the seizures. So
Yeah.
there's other indications for it, but also it was safe. And then I've always heard that from the military, since you were the dean there at the school, Uniformed Services University.
Yeah, to put it in perspective, Paul, the quick factoid for the group. We even with the celebration of the reduction in opiate-related deaths, we're losing about 80,000 Americans a year. The CDC, before they got really severely compromised, put out an MMWR that looked at reported ketamine-associated deaths in 45 states and the District of Columbia over a multi-year period. And the total number of deaths attributed to ketamine by medical examiners on an annualized basis was less than 10.
Yeah.
And that's intentional as well as unintentional overdoses, not a standardized administered dose taken to a hospital under the supervision of healthcare professionals, which is very different than certain former Hollywood stars or other.
Yeah. Well, yeah. And then, of course, that's been a big topic of discussion. You're sort of new to this, and we have a lot of even position papers, all that. I know ACEP and NMSB joined on that.
Excellent.
Yeah. Okay. And then the other thing is, so they've adopted, like you said, in Toronto. Rob, tell us what you have to say in a second. But first, I want to go to Mick Malloy in Dublin. I assume you're there or tonight, right? Mick, are you there? I thought his hand up. I guess we lost it. Maybe something happened.
I think he was on the phone.
Okay, got it. Okay. Well, hopefully, Mick, if you hear us, come on back. Whatever you can, just plug in all that. Yeah. So there's a lot of work that's been done in this realm already. Hey, anybody on the call here was associated or working on that? Some of the things when we had the whole discussion about ketamine, when the anesthesiologist got into it and told us we shouldn't be using it. I don't know if anybody else. Doug, do you remember who else? Was anybody else here on the call working on that project back then? This was what, 2 or 3 years ago?
Hey, Paul, I'll just add while folks are pondering, the one advantage of getting the FDA to okay is manufacturers can then make fixed dose injectors. Nobody's going to do it until if you got to draw it out of a vial and administer it, that takes time. It introduces the potential for dosing errors. So it's just simply creating an economic path for producing
we had a president,
we need it.
Jay Johanningman, a trauma surgeon who's set up things. Jay told us at our meeting a couple of years ago that when they studied what they used for rapid induction intubation, that they had a lot less cases of PTSD when they use ketamine versus other products like Atominate or whatever. And if you're not aware of that, that might be something to look at and get the data on that.
Yep.
Okay. So, and that's a good one. You want to prevent our soldiers. We want yeah. Okay. So, all right. That might be a good angle to go down that way. Okay. Next on my list here is Mick Malloy. Are you back? If not, I'll move on down to Clayton. How's that? Clayton Kazan, you there, dude?
Yep, I'm here. Good morning.
What's happening in LA County?
I will say LA is, knock on wood, relatively calm and stable. Our blood program is it's kind of like everybody else's. It seems like it goes way faster than you think it would. And we're up to 8 units now given between LA County and Compton and ongoing.
Okay, got it. Has it mostly been penetrating injuries for you guys?
We've had 2 of the 8 were ruptured AV fistulas. We've had, we had one that was kind of unknown, and we still don't really know what happened to her. She needs to go to autopsy. We had a major motorcycle accident that was sort of our ideal candidate. We've had another motorcycle versus car, and we had a stabbing.
Okay.
And then Compton gave it to a 12-year-old shooting patient that unfortunately expired. But 12-year-old shot in the park this last weekend.
Well, it's interesting that you say that everything seems to be in good shape over in LA County. It turns out that I talked to Mark this week, and it's just things are like whatever in LA City, you know, that kind of thing. Poor guy. So
Yeah.
I didn't get any specifics about the politics, but I didn't know if it's appropriate to talk about it here anyways. But anyway, so that's it. Nick Malloy, if you're back, we'll take you, and then we'll go on if after that to Crawford. You're going to be next, just so you know. Mick Malloy, are you back? Okay. Well, I'll tell you what, let's go over to, before I do Crawford, if you don't mind, let's go to Russell Baker real quick. Hey, Russell, do you mind? We hadn't heard a good report from El Paso for a while, so anything you got to show or share with us?
Not much going on in El Paso, still struggling with our blood program. Primarily because we have to get our blood out of Phoenix. We don't have a local blood procurement area. So we have a huge problem that we're struggling with trying to get over this hump.
Yeah.
And the only other thing is I also do medical direction for Blue Origin, and we're really ramping up the space tourism and suborbital kind of issues going on. We're doing about a launch every 28 days now is the goal. So we're doing a lot more space tourism out here.
Okay, got it. And then what kind of, are you seeing anything associated with it, either before or after the flights?
Just a little bit of dizziness is pretty much the, a little motion sickness is kind of the only thing we've actually seen.
That's what
we've got more issues with the emergency response team on the ground with snakes and scrapes and twisted ankles and things like that than actual astronauts.
Of course. Yeah, that's great. Yeah. All right. So, so don't pick up the little guy there with the yellow stripe on him, right?
That's right. Avoid a moving noodle. That's what we advise.
That's great. Okay, good. Well, it's great to see it now. Or I can't remember. You said you're not able to come this year, right, to the meeting, correct?
Yeah, that's correct. I'm going to be over on the other end in Hawaii. So
yeah. Okay. Yeah. So here's the. Oh, that's right. That's great. Remember, that was great. Good for you. Hey, next year though, for everybody, just put in your calendars now. Is that it's going to be Monday, June 1st next year, and we're moving out to the beach area where the convention center is at the port, and it's going to be I think a lot better for a lot of reasons. So anyways, I mean, there may be growing pains the first year, but it's going to be much better circumstance. And so that's going to be June 1st. That's easy. Then Eagle Creek will be the 2nd and 3rd, and then the 4th and 5th will be the main Eagles meeting. So again, but now even some respects closer to the airport and just right there near the beaches. Okay. Alrighty. So put that in your calendars. I should send that out probably, or have Jim send it out to everybody so we could start planning our shifts and whatever else that we have to do during that period of time. All right. Yeah. Okay, good. Hey, Crawford, anything out of Philadelphia?
Just a couple things. And I think, Paul, I sent you an article about one of them. So for years, Kensington, sort of our ground zero for our opioid crisis, has been sort of serviced, as it were, by a variety of mobile health units, like mobile clinics that do medication-assisted treatment, that provide wound care, like xylazine wounds and stuff like that, primary care, hand out needles, all that kind of stuff. And for years, the residents of Kensington have not been thrilled with them because these mobile clinics sort of arrive every day, create quite a kind of crowd around them. Their aftermath is associated with a lot of litter and needles and stuff like that. And so long and the short of it, just in the last week or so, City Council fairly overwhelmingly passed a bill to extremely limit those mobile clinics in Kensington. And I think the ultimate plan is to actually permit all of them. So the numbers are going to decrease and they're going to be more localized, I think. And not surprisingly, there's a fair amount of pushback from healthcare folks about what's going to happen with these folks and where are they going to be able to get their street treatment, as it were. And other thing is apparently the mayor has asked one of the state senators to propose into legislation that the need for drug rehab becomes an indication for a 302, so an involuntary mental health hold, like suicide and stuff like that. So in other words, the goal would be to force people into rehab, and it'll kind of be interesting to see how that plays out.
If it win, yeah, right. Okay.
So that's Philly in the last week.
Okay, good. They still have cheesesteaks there, right? So
they do.
Okay, good. I want to make sure. All right. Apparently SAEM is in town. Are you going to that?
Nah, I've been working all week.
I didn't make it. Yeah, right. That's a different mentality nowadays. So, all righty. So then, all right. So we went there. There's Ben Crawford, David. David, you still have the little, you said you want to make a little, whatever, talk about something or other. What was the thing you wanted to talk to us about?
Yeah. So I'm going to bring something up about I'm going to share my screen. So I went to a trauma meeting. I go to the trauma meetings for all the level 3s. And this blood banker came to present to the group because the trauma surgeons wanted whole blood in the hospital. And I just wanted to share with you the other side. So we are very passionate about our use of whole blood in the hospital, in the field. But in the hospital, you have to understand they are very risk averse, very conservative, and they don't want to do more work, right? If they don't have to. And so she had some
I heard that our medical director in San Antonio is really conservative too. Maybe that's the problem.
No. But she had some very good points to refute the use of whole blood in the hospital. And I think we should be aware of them. Okay. So first of all, they like as a custom fit, they need blood. Okay, we'll give them red cells. Oh, they need platelets. Oh, we'll give them platelets, right? So in the hospital, when you know what you got and you have the time, doing that precise replacement, okay, that makes sense, right? And so she said, well, if they're really bleeding, we just use the massive transfusion protocol, and that's available within minutes. Okay, anybody tried to get an MTP in their hospital within minutes? Yeah, no. You have to call, you have to bring the sticker, there's drama, blah, blah, blah. But what she did tell me something that was an eye-opener. And she said, yeah, we use about 1 MTP a month in our hospitals. But interestingly enough, all they give is the red cells. And the cooler comes back with all the yellow stuff. So the plasma, the platelets, and the cryo is never used. So even in the hospitals, they say they use MTP, but they may not be giving them what they bleed, so to speak, because they're just giving them the red cells. So she was also concerned about the fact that, you're going to get recycled blood over 14 days old, that the platelets aren't going to work, and that the coagulation factors are going to be lower, and and some of that is actually true. The other thing that hospital blood bankers get really upset about is the blood we use is not leukoreduced. And so it has white cells. So there is a theoretical risk for transmission of CMV. But that really only plays a role if the patient's immunocompromised, not healthy, And the risk is still pretty low with our blood banking screening process. It can increase HLA antibody thing if they're getting a lot of blood. But again, that's not going to be for our usual trauma patient that's going to get a couple of units, survive their injury and go home. So the blood bankers do have some relative concerns that are valid, but we have to look at the risk-benefit process. So then, interestingly enough, this was a great one. She said, well, what about the cost, right? So the surgeon asked about the cost. So if you do MPT, the National or Massive Transfusion Protocol, MTP, it's over $1,400 for the bucket of goo, right? Now, a unit of whole blood is only $400. So let's say you gave 2 units of whole blood instead of the bucket of fun from the MTP. You're saving a lot of money per patient, and by like almost $400, $600. And also the people that got whole blood, the data's been showing lately that they require less products in the future if they're given whole blood in the ER and the pre-hospital. So you'll save even more money. And then the other thing to refute this whole infection risk is, why would you give the bucket of fun that comes from 5 or 6 different donors when you can give 2 units of whole blood that comes from 2 donors? So if you're really worried about infection, why are you putting your people more at risk? Now, granted, the whole blood, the red cells are irradiated, so you're going to decrease the infection rate for CMV. But the other stuff that pops up you're giving them more risk to exposure. So anyway, I just thought we should hear the other side of the blood equation from the conservative pathologists who actually do have some legitimate points. But in the context of what we want to accomplish, I think the risk benefit issue is a little bit different equation from the ER. So
Randy, yeah, let me jump over to Randy if that's okay. And just get a reaction from her because she worked in the same system before with you and all that. And just anything else to add to that, Randy?
Oh, I'm laughing, David. CJ and I got yelled at sitting in the basement of Methodist Maine with the blood bankers. That was one of our ones I should have worn my body armor for. So I'm making progress.
Yeah. So this was from that same person, Randy.
Okay. They don't change their stripes that easily.
No.
Okay, got it.
But on the good news, unofficially, HCA is at the corporate level changing their perspective on things. So I'm working to help with that effort to get some of those.
I mean, it saves money. That should be like an HCR, Red Star, blah, 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 blah. Hospital Criminals of America, usually.
Money and lives, good deal.
That's right. Save lives, save money, right? Or I mean, save money, save lives. Whoops, sorry. Got my priorities wrong. But so I'm glad to hear that, Randy, because I think the more we use in the hospital, the more we can put pre-hospital, and then the more people will get their service lines up for that.
Yeah. Hey, and Randy, anything new? How's our body count doing? Are we up to about 250 or something?
Yeah, no, I've actually been trying to scrub it as we've been sitting here. So I think by the end of, well, we're almost at the end of May. By June, we'll be at 250.
Yeah.
So we're 240 plus right now.
Yeah, and these are, when we say this, are we specifically talking about ground units versus?
Ground unit. Yes.
Yep. Okay. Wow. Okay. Very cool then. All right. Anything else to report, or you or John?
No, and we're proliferating across the globe. I get to talk to the Spaniards. Actually, I'm going to have a meeting while we're at Eagle Creek with them. I've talked with a surgeon in Greece who's trying to get whole blood and pre-hospital blood implemented. So,
well, just as the person who was medical director for Madrid is on the call with us right now, and we maybe we should get you guys introduced. And he can't make it to the Eagles this year, but still you can do it. He's now up in Iceland of all things, so it's kind of interesting, but he may know the contacts there if that'll help you, and so on. And then that's what I was going to tell them next was the Whole Blood Summit is happening July 15th there, so I've already got my hotel room secured, and so but anyways, so hey, Vicente, but hey, how do you pronounce your last name? Is it Ingelmo, or how do you like to pronounce it? Vicente?
Ingelmo. That's probably a funny Spanish pronunciation of probably a Northern European name.
Yeah. Yes. Okay. So, anyways, so I just wanted to introduce the Randy, who's helping us to proliferate the use of whole blood in the streets out there, and I guess she has some contacts. Do you know who the people are that you have contacts? Because I suspect that Vicente would know who they are.
Yes. Yeah, there's a HEMS group out of Ciudad de Real that's going to have a conference coming up, and I cannot remember his name.
I'll connect you guys up offline here. I can move on. Just wanted to make sure you understand. Well, I got you on then. Anything new to report out of Reykjavik or the country?
Nothing new or exciting happening. The weather is absolutely fantastic. Best day of the year so far.
Good. All right.
And then getting ready for two events. There's an Nordic health preparedness conference in Finland next early this week. We're going there. And also there is an EMS benchmark indicators benchmark meeting in Reykjavik on the 26th to the 29th of the Nordic and Baltic countries there coming in Reykjavik, probably producing a new report, 2025 report.
And thanks for your presentation about Iceland, whatever it was a couple of weeks ago. It was fantastic. It was really good. And then I'm going to tell you that thing when we talked about the Iberian blackout, that is having some significant, it's changing things. So I'm glad you brought that up. That's really, really good. So thank you so much.
No,
all right.
welcome.
Hey, so before I go to Glenn and some of the others, Stein, obviously we're kind of out of time because you got pulled off. So I'm thinking, which is really great because I don't have the agenda I put together. Nobody could show up to do it today. So what we'll do is I'm going to keep the same agenda for next week. Whatever you got this week, it's just it's going to be deja vu all over again. So does that sound okay to you, Stein?
Absolutely. Sorry, my presentation went over at this trauma conference about blood. Yep.
Oh, that's great. Yeah, but it's fine. I mean, with us, it's just like, fill us in, and we wanted to serve you because you wanted to discuss it. But Dustin, can you make it next week as well?
Yes, sir.
Then why don't you guys talk if you want to talk about how you could sort of, hook up and just, see what you're going to talk about. You can sort of do color commentary and all those kinds of things by, knowing where Stein wants to go with this. And then Stein, I understand that there's a warning about someone coming into your jurisdiction on Sunday. Is that true?
I think that's true. Yep.
Okay, good.
Looking forward to having you.
Okay. Well, I was going to say we'll warn the Office of Emergency Management because there's always some disaster when I show up. So, all right, good. I'll see you. I'm looking for. What time am I getting in? Around 3:30 or something like that? 2:33.
I think so. Yes.
We'll regroup on that.
We'll regroup. Yep.
Yep. Good. Okay. Hey. So Glenn, anything out of New York City? Oh, sorry, New York City, right?
Hey, good morning.
Yeah.
So for the last 9 weeks, I've been pretty busy with complaints from the hospital end and such.
Yes.
We actually 9 weeks ago stopped allowing patients to go further than 10 minutes from the closest hospital for the low acuity stable patients. So we used to have a 10-minute rule that from your location, if the hospital you wanted to go to was 10 minutes from the closest, so up to 20 minutes, we would allow you to go. Our commissioner said, why are we doing that? We are not a Lyft or an Uber service, and we are an emergency service. So for the low acuity calls, stable, again, we do not allow that to happen anymore. So it's supposed to be the 2 to 3 within 10 minutes of the location. Our computer assisted dispatch system is not quite working that way. So we've been fielding calls from the Greater New York Hospital Association, which represents the hospitals. And their claim is that we are harming patients by doing this. So this really doesn't apply to any of the critical patients, the STEMI patients, the trauma patients. They go to the closest appropriate facilities, as was always the case. The other issue is our online medical control physician has the authority to make the medical decision to approve a transport if he or she feels it's medically necessary. The hospitals are saying that they are not having their patients come back to them for the continuity of care, and that's detrimental to their patients. But I have gone on saying that continuity of care does not equal medical necessity. So it's been a little bit of a battle. They've sent us cases. I've reviewed close to 100 cases where they said we harmed someone, but we didn't harm them, and it had nothing to do with the policy change of the low acuity stable patients. And I tell them that if we intubate a patient in the esophagus, that's a call that the emergency department will make to me immediately. And they should, because we need to figure out what happened. And in a lot of cases, those paramedics will be restricted and will do an investigation. And they claim all these horrible cases, and yet I didn't get anything for really 6 weeks. So I'm saying, if you're saying we're harming them, I need the date, the call number, so we can investigate this. And nothing had come over. So we're in a little bit of a battle. The New York Post said that, the media reports it incorrectly, that you only have the choice of going to the closest hospital. And it makes it sound like it's in all cases. That is not the case. And I'm trying to tell our members now, let the people know, patients, that we're not denying transport for you. You're just declining to go to one of the 2 to 3 state certified 911 receiving emergency departments that can handle your potentially even your fractured finger, right? That kind of stuff. You don't need to go to network for that. One of the interesting things I get is, I might be the telemetry physician, and I hear a patient in Brooklyn saying, oh, I want to go to New York Presby Columbia because I want Dr. Oz to see me. And I laugh. I'm like, first of all, Dr. Oz is not even there. He's not going to be seeing you. So those kind of things of, oh, my records are there, is I've instructed my physician, that's a no. You can't go to a facility that, it's so far just because your records are there when the closest 911 receiving emergency department can handle that.
But you're not so close-minded that if it's a true, like, I don't know, cardiological thing and they had the records there, but if they're broken their arm or they did, whatever, things like that, that could be handled anywhere is what you're getting at, correct?
Right. And even they might say they have a broken arm and they say, well, my cardiologist is at New York Presby Cornell. I'm sorry, it's not a cardiac problem at the moment. So you're going to go to the closest.
Yeah, okay. All right, we're going to have to sign off. But Mick, I guess we got you back on, right? You had your hand up before, and we missed you. Are you still there, Mick Malloy? Wonder why we're not hearing from him. It looks like his microphone's on. That's why I was wondering. Okie doke. Well, all right. I don't know if I've missed anybody here today. And then Dustin, you can report on whatever you want to report on next week. How's that? Does that sound good?
Yes, sir. That'll work.
Okay, Mike, anything new out of Toronto that we should know about, or besides the fact that you're putting ketamine out there?
Nope. I mean, I have the occasional thing, and I know we're out of time, where our CBRNE paramedics are called, and I'm talking emergency physicians and nurses through treatment of organophosphate poisonings, and these are pesticides, not chemical warfare agents. I'm wondering if other people are having to get their medics to go to the hospital to treat the patients.
Yeah,
already in hospital.
Jim, you want to quickly address that, Jim Augustine? But then, why don't you come on and tell us? Well, why don't you come on and make this one of your discussions on one of these sessions, okay? And we can go over that in more detail. But
be happy to.
Yeah, Jim, any quick reaction to that, since that's sort of up your alley a little bit? Jim Augustine, or we lose him? We lost him, I guess, right? Okay. Well, whatever, or anybody else wants it. But let's talk, make it one of the subjects, and we'll talk about it then, with other people, okay? So that's it. I think I've got to capture everybody pretty much from the cities. Stein, you're set, right? And then you were asking me again about the IV solutions, Terry. You want to do that sometime? And give me a heads up, and I'll the day before, and I'll put it on the agenda.
Okay, I'm speaking to the gentleman who developed it this afternoon.
Okay, good. Well, then give us a follow-up then, maybe next week. Just remind me to put it on the agenda then, okay? So,
okay.
Good. Libby, anything we need to know about Hawaii? Are you still on?
Yep. No, nothing earth-shattering here. Just been working with NDC, MPH, and the stuff that Art's talking about to be able to receive war wounded.
Okay, good. Okay. Obert, David. Thanks again for that great presentation last week, or whatever it was. Was it last week or the week before? I can't even keep track anymore. So
yeah, no, absolutely. Thanks for the opportunity. Really, the major update that I think I had mentioned a couple of weeks ago on an Eagles call is we've just wrapped up a major coroner's inquest into a case. The jury released their findings yesterday. Essentially, the main takeaways were an instruction to the Ministry of Education in British Columbia that all high school students in the province receive CPR training. And as well, some interesting pieces for BC Emergency Health Services and the International Academy of Emergency Dispatch. This inquest got right into sort of dispatch, some of the major controversies, perceived issues with MPDS. And the mainstay for the ambulance service was an emphasis on improved dispatch technologies. And then for the Academy of Emergency Dispatch, really bolstering the ability of the protocol to address multiple non-traumatic patients and having early send points for that. So it was quite interesting. I'd be happy to, I will be attending Eagle Creek, but it'd be something I'd love to present on what we learned from this case and to get the group's feedback on that.
Okay, good. That's it. We could do a trial run in like a week or two, and then maybe have you present there at Eagle Creek or something like that. Okay, just remind me. That's all. It's just,
Okay.
All right. I think pretty much I should probably wrap it all up. Anybody else want to just pipe in? Anything else you want to say? Anybody out there before I close everything off?
Yeah, two things, Paul. One of them is I love Bastille Day, and it was available. I think you said something about something in DC with related to strokes. So my ears open if there's something you hope we can help
we're
with.
going to contact you because we're not sure yet, but it may be the end of the week of June, July 14th. I told them there was a conflict, with our National Blood Summit that was on, I think it's Tuesday the 15th.
That's right.
So I said, if we did that, I'd have to wait till the end of that week, like the Thursday, Friday, which would be more like the 16th, well, more like the 17th, 18th is what I was thinking. Okay. Does that help you?
Okay. And then the other thing is, if that little thing I briefly showed our PRC agenda, one of the discussion things was, we have a prohibition on the analgesic dose of ketamine for abdominal pain, but we're seeing in the literature that is maybe overblown, and I was wondering if those jurisdictions using 0.2 per kilo analgesic dose, do they have the same restriction for abdominal pain? Obviously, musculoskeletal is more common, but I'm not sure if the science says that you automatically shouldn't use it in abdominal pain, but it's a thought, and we're thinking about doing a lip search to find out.
All right. Well, see what you find out. Maybe give us a quick report on that, and Art can be on with us at that time as well. So, okie doke. So, all right. And anybody else has anything else? Let's see. Oh, I just want to see. Mick is just, hey, Paul, system frozen. Okay, got it. Question related to paramedic under physician license. Is there? Okay. Well, I'm gonna have to come back to this next week, I think, unfortunately. Okay, so listen, everybody, welcome back, my friends, to the show that never ends next week. I think I may even have the Pope's doctor on with us next week or the week after. It would be kind of cool. So we may have a crowded agenda, but we'll see. We'll just, as usual, play it by ear. And he and I are good friends, and we were in communication during the whole demise of the prior Pontiff Francis, and but he was just in a different position at that time. And so it has good comments to say about the new guy. And so that'll be kind of a fun little diversion from our day-to-day stuff. All right. Well, listen, I'm getting tired of getting yelled at in hospital basements myself. So we're going to move on to other arenas today. We hope you have a great weekend, everyone. Thanks a lot. See you next Friday. And that would be the 23rd, I think. Okay. Thanks. Thanks for joining us, Art, by the way. That was great to see you. Okay.